Hello everyone. Today we will be reviewing the placement of an infrarenal inferior vena cava filter or an IVC filter. The goal with placement of an IVC filter is endoluminal caval interruption to prevent pulmonary embolus. While this may seem like an easy decision to place a filter, the interventionalist must first determine if the patient truly needs a filter and then what type, retrievable or permanent, should be placed. Per the practice guidelines established by the ACR/SIR in 2010, there are two groups of indications: the therapeutic indications, patients with documented thromboembolic disease, and prophylactic indications, patient without current thromboembolic disease. The therapeutic indications include patients with evidence of a PE or IVC, iliac or femoral popliteal DVT with a contraindication, complication, or failure of anticoagulation. Patients with a massive PE with a lingering DVT, a free-floating iliofemoral or IVC thrombus, or severe cardiopulmonary disease with a DVT. The prophylactic indications include patients with severe trauma, such as a closed head injury or spinal cord injury, or having multiple long bone or pelvic fractures, and high-risk patients, like those who are immobilized or stationed in the ICU. When choosing a filter type, you must look at the entire clinical scenario, but there are two unequivocal indications for a permanent filter. The first is recurrent PE on therapeutic anticoagulation, and the second is a PE with a contraindication to anticoagulation. Careful selection is key because permanent filters thrombose about 10% within 5 years. With relative indications, again, the entirety of the clinical scenario must be evaluated. Severe cardiopulmonary disease with a DVT should receive a permanent filter, while the high-risk patient, the temporarily immobilized, should receive a retrievable filter. Patients with free-floating iliofemoral or IVC thrombus or following severe trauma could receive either a permanent or retrievable filter. There are two relative contraindications for this procedure, which includes an uncorrectable severe coagulopathy and bacteremia. The anatomy for this procedure is relatively simple. The goal is to place the filter below the renal vein, so if filter thrombus occurs, the renal veins will be spared. With conical filters, their tip should be at the level of the renal vein, so the blood flowing in helps to dissolve forming clots. Now to discuss the procedure. This procedure can be approached from either the right femoral or right internal jugular vein. This video demonstrates the right femoral vein approach. Like all procedures, the patient was prepped and draped in the sterile technique. The bilateral inguinal regions were prepped for this procedure. The patient then receives Versed and fentanyl to provide conscious sedation. The common femoral vein is then identified by its compressibility and lack of pulsatility. It is also evaluated for patency to make sure there are no DVTs in the region prior to starting the procedure. Lidocaine is injected to provide local anesthesia. After waiting for the local anesthetic to take effect, the interventionalist uses the Seldinger technique of puncturing the vein, sliding an access wire in, checking its location in the vein, exchanging the puncture needle for a catheter, the micropuncture wire and indwelling 3 French dilator are removed, leaving a 5 French micropuncture catheter in place. Next, a Benson wire is advanced. This image shows the wire has advanced past the pelvic veins and IVC and ends in the SVC. The catheter used in this procedure has an inner portion and a long outer sheath. The tip of the inner portion will function as a catheter, and the long outer sheath will help in the final deployment of the filter. This device is then flushed and loaded onto the wire. This image shows the catheter being advanced into the IVC. The portion that indicates the length of the filter is highlighted by the two dots at the end. After positioning in the IVC, the catheter is prepared for contrast injection for the pre-deployment vena cavagram. From this cavagram, we need to assess for size of filter and the patency of the IVC. The tapering of the contrast that we see is due to the renal veins diluting the contrast. With this cavagram, we can choose the appropriate size filter. Here, you can see the filter being compressed by the clear outer sheath. A wire is placed in the catheter to allow for exchange. For the filter device, the filter is aligned in the infrarenal position, then the clear outer sheath is slowly removed as the filter deploys. These images show the filter struts expanding as the outer sheath is removed. Here's the filter, fully deployed and in satisfactory positioning. Appropriate positioning and deployment were confirmed using this post-deployment vena cavagram. The long-length IVC filter sheath was removed from the right common femoral vein, and hemostasis was obtained using manual compression. Following the procedure, we need to be aware of the potential complications. The range of the occurrences of these complications is provided in the parentheses. These include access site thrombosis, IVC perforation, when the struts penetrate the caval wall, which can make the filter irretrievable, incorrect deployment, such as being outside the target area or being at a tilt. Filter embolization can occur with incorrect sizing. Finally, IVC thrombosis can occur, which is then usually compensated via collateralization with the ascending lumbars. The follow-up depends on the type of filter placed. With permanent filters, the filters will remain in the patient. However, for retrievable filter, the interventionalist needs to assess the clinical context to determine the timing of the retrieval. Thank you very much for your attention, and we hope you enjoyed the video.